So I'm going to talk briefly about a method for detecting bias in treatment decisions. And again, my perspective is sort of has two sides to it, both as a cardiologist at the Massachusetts General Hospital and as a faculty member in electrical engineering and computer science at MIT. And I like to sort of begin these talks just a little bit and follow up somewhat on the comments that I made to my opening remarks. So healthcare. Today, there's patient provides information to the healthcare provider. Information comes in a variety of different forms, and the provider uses this information to be able to make decisions with respect to the patient, the medications and procedures that will benefit that patient. As I mentioned earlier, though, there are lots of issues that come into play here, that these decisions do not happen within a vacuum. There's a context and additional features that can make the decisions non-optimal for the patient. So there are patient-level features, again, the beliefs and preferences of the patient. There's implicit bias, or sometimes even explicit bias on the side of the provider. There are issues, poverty, wealth, unemployment, access to insurance that all come into play. And all of these, at the end of the day, can lead to incorrect treatment decisions. These incorrect and biased somewhat interchangeably. Now, what do I mean by an incorrect treatment decision? Well, using the word biased in a statistical sense, the tendency of a statistic to incorrectly estimate a parameter for a defined population. The related concept is it being incorrect, which I think is a little simpler to get one's mind around. So an incorrect treatment decision is one that doesn't benefit the patient. So in other words, better outcomes would be obtained if the therapy was not administered or if an alternate therapy was given. So incorrect treatment decisions lead to poor outcomes for the population of interest. Now, why do incorrect treatment decisions happen? Previously, I talked about structural features and patient factors and provider factors that come into play. But if we just try to isolate the discussion from the standpoint of the patient and healthcare provider, I think it is instructive. So the patient, again, provides information to the healthcare provider. And the healthcare provider has to, when considering a particular therapy, asks, well, the effect of that therapy on patient X, is that going to be beneficial or not? And in other words, if the provider administers the treatment, will the patient feel better? Will they live longer? So the physician is doing a complicated task. And in this case, she is trying to estimate the individual treatment effect, which is precisely what I've outlined here. What will happen if I give the therapy? What will happen if I don't give the therapy? And if the outcome of interest is improved with the therapy, then I should give it. Mathematically, this is just a difference in expectation values. If Y is the outcome, let's say whether they survive or not, given the patient characteristics, and 1 t = 1 if the therapy is given, and t = 0 if it's not. So you could say, phrase this another way, what is the individual treatment effect for this patient X and for a particular therapy in question? So phrasing it like that, we can be a little bit more precise about what an incorrect treatment decision is. So an incorrect treatment decision corresponds to instances where the physician's estimation of the individual treatment effect is inconsistent with what she does. So if the individual treatment effect suggests that the therapy is appropriate, right, and then the therapy is not given, then that's an incorrect treatment decision. So poor provider estimates of the individual treatment effect lead to incorrect treatment decisions. And those things can happen because the provider has incorrect or insufficient medical knowledge, and that's because the data in which one uses to make these decisions is itself biased or inaccurate, or incorrect data is provided to the decision maker, and there's all of these sorts of biases. And it's hard to disentangle all of these, but at the end of the day, what happens is that the patient suffers. So what I want to discuss is ways to understand precisely when these incorrect treatment decisions happen. So our strategy for finding incorrect treatment decisions in a particular data set is as follows. And this was done by work by a very talented student in my group by the name of Wangzi Dai. So suppose we're given a data set of patient characteristics, treatments, and outcomes. We want to learn a model that estimates the treatment effect. And there's nothing new here. This is a big area in the field of causal inference. And then we say the treatment is incorrect, where the individual treatment effect from the data is estimated to be favorable, but yet still the treatment is not given, and vice versa, when an individual treatment effect is said to be unfavorable, and yet the therapy is given. So essentially, we want to build a model. We want the model to tell us for each individual patient what is the estimated treatment effect. And we can go back and say, well, did the provider give the treatment even though the individual treatment effect was wrong? And we're going to call those potential bias in a data set, or potential bias clinical decisions, or just more simply incorrect clinical decisions. And we want to eventually look at the characteristics of those patients who got incorrect treatment decisions and see if we can find some patterns as a way of detecting when there are bias in clinical decision making of the data set at hand. So overall, the model attempts to learn the joint distribution of a patient characteristics, treatments, and outcomes. And I'm not going to go into the details here, but I'll just say that we use what Wangzi did, is developed a contrastive variational autoencoder, which learns these relationships in a very efficient way. So we calculate the individual treatment effect once the model has learned this very broad distribution, which is a difference of two expectation values. And then given a joint distribution, we can also ask what patient features have the greatest influence on the outcome, and actually whether the specific therapy is administered. So we did this in practice. We took a look at the data set called the GRACE data set, which is a global registry of acute coronary events. It's a very large data set that's been acquired for over 10 years, 250 hospitals. We took a look at a subset of about 15,000 patients who presented with an acute coronary syndrome. And an acute coronary syndrome is an event that's akin to a heart attack. It's when essentially the heart muscle is denied blood. Patients typically present with chest pain, and it can be fatal in the most severe cases. And the treatment is coronary artery bypass surgery. So again, all patients that presented with an acute coronary syndrome, the treatment of interest is whether they were referred for bypass surgery, which is a way to fix the blockages in the vessels or bypass the blocked vessels to the heart to restore blood to areas of the heart that aren't getting enough blood. And the outcome of interest is death within the first 6 months of presentation. So we built a model, and I'm going to not go through all the details and verify to some extent that it was delivering data that we could trust. And the first question is, what are the founding features with respect to the outcome? So what characteristics among the patients most influence whether they live or die? And some of these are pretty obvious. These are the list of subset of the features that were considered, and these are p-values. P-values less than 0.05 suggest that that feature plays an important role, or I should say is correlated with the outcome of interest from the model. So age is, pulse is, blood pressure is on presentation, renal function is, but gender comes out as being very significant, and its level of significance is close to what it is with blood pressure. So also, we can also ask, well, gender affects the outcome of death to patients, and why is that? Well, what also influences the treatment that is prescribed, whether the patient is referred to get bypass surgery or not? Age comes up as being an important factor that you can sort of rationalize. Patients, a patient that's 90 years old might not be referred for bypass surgery because their risk of living through the procedure may be low. Presence of cardiac arrest, blood pressure, but gender, again, comes up as being an important confounder that determines when therapy is administered. And its level of significance is the same as that of the presenting blood pressure. Similarly to what we said for the outcome of death. And lastly, we can ask, well, when are the treatment decisions inappropriate or incorrect? When is the estimated individual treatment effect not consistent with the treatment that was administered? And if you look at the characteristics of patients that had incorrect treatment decisions, two features come out as being very significant. most significant of the ones we looked at, whether there were ST segment changes on the initial electrocardiogram. So that is whether the clinician in looking at the presenting ECG saw signs consistent with ischemia. Those paradoxically are associated with bad treatment decisions. And again, gender comes out as being important. So in all of these cases, gender is associated with significantly with worse outcomes. This is with the probability whether one is prescribed, is referred for cardiac surgery, and is significantly associated with incorrect treatment decisions. So what I've talked about here is you've got the patient, we've got the healthcare provider, and we want to ask the healthcare provider, when are they making incorrect treatment decisions? And what features are they using to make these decisions about therapy, and how do those decisions affect outcomes? And we can do this in a data-driven way. As applications of machine learning become more pervasive, this paradigm will change, as it slowly is, in that the information will be relayed to some algorithm, and that algorithm will occasionally make decisions on its own, depending on the problem, or it may confer additional data to the clinician that they can use to make more informed decisions. So the methods that we've talked about, that I talked about, really was in a context of doing it with respect to the provider. But we can ask the same questions of the machine learning algorithm to find out when the algorithm is likely to make incorrect treatment decisions and what biases that it may have. And that's the formalism in which we hope that this method can be applied as a way to test biases and when the algorithm is actually making the best decision for individual patients. So in the last 4 minutes that I have left, I'll just talk about a related issue. Oftentimes when we discuss bias, we have a predefined notion of the groups of interest. So we'll say, well, we know there are marginalized populations, and we want to say that look at the performance in these marginalized populations with respect to other populations. And that is a very important thing to do. However, can we ask a priori, when is the model likely to not perform well? So let's say I have no prior information about what subgroups are important, which performance may suffer. And I just want to ask a question generally. So we also thought about identifying methods for finding populations where the model performance is poor with little a priori information, little prior information. So we call this finding unreliable predictions. And just to go quickly, because my time is running out, if you have one population, a training data set, and you sort of build one model for one predictive task, and then you have some new patient that comes along, and you want to apply this predictive task, you see what the prediction is for that patient. So let's say the predictive model is who's going to die in 6 months after presentation with an acute coronary syndrome. And use this training data to be able to get your prediction. You have a new patient, you want to apply the same model. So very simple way of doing this, you train a separate model to accomplish the same predictive task using the same data set. So two different approaches to get at the same predictive task. You apply these two methods to the patient, and when they disagree, we say that the prediction is unreliable for that patient, and that and we say that such patients that have these big differences in these two predictions, the model is likely to perform poorly because the data set is not sufficient to get a robust estimate for that particular patient. So from this, we developed what's called an unreliability score, and we want to say the idea behind the unreliability score is it identifies patient subgroups in which model performance is expected to be poor. I guess Ziad showed some plots. I showed one equation, that's it, just to show you that you can develop an analytical expression for this. And this is based on used also some generative models for each of the different classes of interest. So we built this model and we applied it to, we used this method and applied it to known existing risk scores. And here in this black line, this is sort of a calibration plot, observed risk, predicted risk. And these are the black line are for the patients that have low unreliability, that are most reliable. And for the red line, you see that it is the most unreliable predictions, those patients that have high values for this unreliability score U of X. And you can see that the predictions are wrong in this case. Moreover, if you look at the average performance error, so this is akin to the Breyer score, the error is much higher in those patients that have the highest unreliability score. And the discriminatory ability is lower also here. It's for the race models 0.8 and it's about 0.5 for the unreliable predictions. And we apply this in different models as well. So just to summarize, these are reliability metrics. I think that a priori identifies subgroups where performance is poor. It serves as the basis to try to understand where the model is not going to perform well without bringing any prior information about what subgroups are important. And then identifying model biases, I think, is one way to quantitatively look at, perform checks on models and on people to determine when bias occurs. And I just want to mention members of my group here. Okay, so I think I have stopped sharing. And again, I'll leave questions for the last bit.